Ladies and gentlemen, dear colleagues, first of all, I would like to thank you for this kind invitation. The topic I would like to speak on today is about the diabetic food team approach and Charcot food management. As you know, in the past, diabetic food was considered synonymous with malperformance, with neuropathic plantar wounds. But actually today we know that diabetic foot is something more difficult, more complex. We have a neuropathic foot, Charcot foot, and ischemic or neuroischemic foot. But today we consider also patients without any history of ulceration, but at high risk or at risk of ulceration, and patients who do not have any ulceration, but in their history, they have an ulceration or minor and major amputation. In the first case, we talk about primary prevention, and in the second case, we talk about secondary prevention. And of course, we have patients with active ulcerations, surgical wounds, etc. But the main problem among patients with diabetic foot is not the amputation, is not the risk of ulcerations, but is the survival rate. Today we know that there is a huge difference in patients with diabetes and patients with diabetes and ulcerations, because the risk of death at 5 years for a patient with a diabetic foot ulcer is 2.5 times as high as the risk for a patient with diabetes who does not have any foot ulceration. And actually, these common complications of diabetes have higher mortality rates than the most common cancers. You can see here prostate cancer, breast cancer, Hodgkin disease, and even in our experience, patients, for example, with ischemic diabetic foot, they have a 5 years mortality rate around 50%. These are patients who underwent a successful revascularization, a successful limb salvage procedures. And moreover, when you consider a primary amputation, we need to be very careful, because primary major amputation results in shorter survival, higher risk of subsequent major amputation, and of course, higher healthcare costs. So today we consider diabetic foot as a syndrome. Diabetic foot syndrome leads to a high risk of amputation and mortality. So a diabetic foot multidisciplinary team is required for its management. Diabetic foot multidisciplinary team should be organized with 4 specific teams: the medical, the foot surgical, the vascular, and rehabilitation prevention teams. And these are the skills and actions for each team. You can see for each of the 4 teams, we have different specialties, different actions, and different skills. Team leader is really important in order to build up this kind of strategy. We have to identify a team leader with these characteristics, but the most important characteristics must be the ability to interact and to cooperate with the other team members. About Charcot foot, you can see here in this very beautiful old paint some of the most important influencers in the neurological disorders field. I can give you an help in order to identify them. You can see Charcot in the center of the paint. We can see Babinski, we can see Latourette, and some other important colleagues, still important today. The first description made by Charcot about the Charcot foot has been written in the 1883. Today we know that now, considering inflammatory syndrome, the diabetic Charcot foot is characterized by varying degrees of bone and joint disorganization secondary to underlying neuropathy trauma, and perturbations of bone metabolism. And these are some of the most important diagnostic recommendations for the active Charcot neuropathy. The early stage is really important, and the diagnosis of active Charcot foot is primarily based on history and clinical findings, but should be always confirmed by imaging. Early diagnosis means to reduce the risk of further complications or late complications of these terrible complications of diabetes. Diagnosis is important, and we have to use the patient's history, clinical findings, imaging, differential diagnosis. History is really important. We have to know about the duration of diabetes, presence of neuropathy, previous trauma or surgery, recent increase of the activity level, patient's activity level, previous acute episodes, and modification of the shape of the foot. And from a radiological point of view, we have different stages of the disease. You can see in this Hichenol's classification system, we have 3 stages according to the difference we can find in the radiological findings. But the most important thing is to keep in mind that stage zero, when we do not have any change in the radiological findings, is really important, because at this stage we are able to reduce the risk of further complications of further deformity or ulcerations or osteomyelitis. There are some clinical findings that could help us to do the difference between the acute phase and the chronic phase. You can see here, usually in the acute phase, we have all the inflammatory signs, foot swelling, redness, increase of skin temperature. We can have pain despite the presence of neuropathy. This is a typical acute Charcot foot, but it is really important to do the differential diagnosis in order to confirm the correct diagnosis. You can see that we have some clinical situations very close to the clinical signs of the acute Charcot foot: erysipelas, lymphangitis, deep venous thrombosis, gout, septic arthritis, and osteomyelitis. Role of imagings are really important. The role of imaging is really important in order to assess the presence of structural damages, to understand the nature of the pathology, to evaluate the extension of the disease, and to guide, of course, the treatment, monitoring the outcomes. Sandler-Kleinberg's classification system is one of the available classification for the Charcot foot. It divides the syndrome in 5 different types according to the foot site: forefoot, midfoot, hindfoot, ankle, and calcaneus bone. We could think about conservative treatment in some patients, for example, in the early diagnosis, in the acute phase, with the offloading, off-bearing, medical therapy, and of course, active follow-up. But there are sometimes patients who need surgeries, who need to undergo a surgery in case, for example, of osteomyelitis, in case of non-plantigrade foot or structural deformities that can put the patients at high risk of ulceration or amputation, considering the compliance and, of course, the quality of life of these patients. Follow-up is really important in order to monitoring of the activity phases, in order to assess if we are in the acute, in the quiescent, in the chronic phase, evaluation of the stabilization if you carry out surgery, or indications for surgery, prevention and early identification of recurrences, diagnosis and treatment of complications, for example, osteomyelitis, systemic evaluation, and customization of therapeutic strategies. So I hope that you enjoyed this lecture. I hope to be very comprehensive in this 10 minutes talk. And I would like to thank you again for your kind attention, but also for this kind invitation. Thank you.